Dr. Shreyas, can you screen
Yeah,
share? I'll just stop this.
very nice talk, Dr. Suchi, and it's always a pleasure to be here. And thank you so much, everyone. So I'll just take you all through the management of chronic sequelae of SGS very briefly, and we'll debate why immunosuppression is really not necessary in these patients. Now, let us first understand Stevens-Johnson syndrome itself. Now, while this picture looks horrible and horrendous and is a very acute blistering disease, and the patient is obviously in a great deal of discomfort, you can see that the cornea behind is absolutely clear, pristine, and the luster, even the luster, corneal luster, is maintained. Acute stage itself, the corneal surface itself is not directly involved in the disease. But unfortunately, over a period of time, because of the acute insult, the posterior margin of the gets invaded by the keratinized epithelium from the anterior lid and is replaced and is destroyed. And you have this triad of a dry eye, lid margin keratinization, both of which contribute to having a secondary limbal stem cell deficiency. This causes recurrent epithelial breakdowns. This keratinized surface, as well as the dry eye, causes recurrent epithelial breakdowns, recurrent bouts of inflammation, which can lead to subsequent sterile melts, vascularization, and corneal scarring. Very often, we look at this extensive amount of keratinization, and these are patients where the lids are treated. But very often, the keratinization is not so obvious. It might be very mild and just a migration of the stratified squamous epithelium, which might be quite subtle and might be missed in a number of patients. So it's exceedingly important that we go ahead in this kind of patient who had, you can see extensive vascularization, a lot of corneal scarring, visual acuity of only counting finger 1 meter. And all that was done for this patient was a lid margin mucous membrane graft. If there is one message that you need to take home from this debate or this talk, is that almost the entire subset, except very mild patients of Stevens-Johnson syndrome, almost the entire spectrum of moderate to severe patients of Stevens-Johnson syndrome will have varying degree of lid margin keratinization, and addressing these lids by removing the affected posterior lid margin as well as the tarsal conjunctiva and replacing it with a mucous membrane graft goes a long way in maintaining the corneal surface, the ocular surface of these patients. For paucity of time, I will skip ahead and not show you the entire video. But that same patient with a counting finger 1 meter vision, just an MMG, no further immunosuppression, went on to have a great stabilization of the anterior surface and visual acuity without any other scleral contact lenses improving up to 612. Scleral contact lenses also are an exceedingly important part of management of SGS. They go on to improve vision in these irregular corneas, reduces the contact of the lids with the ocular surface, and works extremely well in combination with mucous membrane graft. Once you've stabilized the surface with mucous membrane graft, you put the patient on scleral contact lenses and give them adequate lubrication. These patients do exceedingly well. There's an excellent paper from LV Prasad, which shows in children, because this is really the subset where you're looking at for long term. And over a period of even greater than 8 years in this subset, you can see that there is a progressive decline of vision in patients who have been managed conservatively or with just immunosuppression. But once they have been combined with a mucous membrane graft, and there is a significant improvement, not only an improvement, but stabilization of the vision as well. And when MMG is combined with scleral contact lenses or PROS, which was used there in the study, there was a significant improvement in the vision, which maintained throughout the duration of the follow-up. Of course, you can occasionally do Aloe Slit in patients, especially after a lid mucous membrane graft, once you have stable surface and adequate wetting. This is possibly the only subset which is really going to require systemic immunosuppression to maintain the surface. Again, if it's a dry eye, you can't do it. You'll have to combine it with a minor salivary gland transplant. But these are a subset of patients, when used cautiously, can be useful. Again, in the dermalized surface, these are patients, again, these are stable surfaces. But to rehabilitate them for vision, you need to either do a type 2 K-Pro, OOKP, or a modified type 1 K-Pro as shown in this picture. Again, this is a dry surface, but a very thin pannus. These are patients where you'll have progressive keratinization because of a very dry surface. Even with systemic immunosuppression, this keratinization is going to proceed. And these cases, you can't do, you'd either have to do a type 2 KP or we do a modified LVP keratoprosthesis, as I've done in this patient, where initial mucous membrane graft was done, and then the MMG is raised, the K-Pro is placed in situ, and it is put back again. Now, is there any role? It is an acute idiosyncratic reaction. We have seen even reintroduction of the offending agent. There are a number of my patients after the K-Pro where they have had a sulfur drug allergy which has caused the SJS, but now are being treated with Diamox. There is no recurrence of SJS. There is no relapses or recurrence in other mucocutaneous tissue, whether it is the skin or the oral mucosa. You don't get recurrent episodes of inflammation. What the papers which Dr. Suchi Smita referred to, both Dr. Chodosh's group as well as John Dutt's group, Royas et al., they've all shown increase in acute phase reactants, inflammatory mediators only in the ocular biopsies. There is no concomitant increase in the sera. So when you don't have that, are you over-treating these patients with systemic immunosuppression? Yes, a number of these patients with dry eye, with breakdown of the surface, giving them topical steroids for a duration, they do feel comfortable. But these are again patients, we must remember, it is a combination of dry eye, which is already established, and the rough lid margin, which is causing these breakdowns and causing these recurrent episodes of inflammation. And again, there is no improvement in the extent of dry eye subsequent to starting systemic immunosuppression, as you would normally find in, let's say, in patients of Sjogren syndrome, where once they are well controlled systemically, you find that the dry eye symptoms are also better. So staged and appropriate management is necessary, and you can give promising results even in dismal situations. But systemic immunosuppression, with the extent of side effects that they bring in over the long term, these are patients who are going to live with SJS for their lifetime. And I don't think there is any role for systemic immunomodulators throughout the course of this disease. Thank you so much for your kind attention.
Brilliant. Yes, brilliant.
Brilliant.
Thank you.
Excellent talks.